My name is Forrest Lien. I'm an LCSW. I'm semi-retired in Arizona. So I created Lifespan Trauma Consulting to do consulting with families and help them with some direction for where to go with their RAD kiddos.
How did this all begin for you in your career? Tell me about when you began graduate school and what you were hoping for back then.
The reason I went to graduate school is because the Casey Family Program, which some people don't know about, they used to do long-term foster care for kids that ended up in the foster care system, and it was an alternative to adoption as being the only answer for permanency. And so I liked the services they could provide for families and kids. I liked their philosophy, but they said you have to have an MSW. So I applied to graduate school and got in the University of Nebraska. And while I was there, I focused my education and training on child welfare. I did an internship with the Department of Human Services there, working with foster kids, and that's where I really got inundated with the whole attachment disorder piece, because in one of my child welfare classes, Foster Klein came and talked to our class, and he was talking about attachment disorder, and I started to put these kids that I worked with in residential treatment and in the current foster care system as having this problem and why they couldn't make it in families. So that enticed me to get all the information I could get on this disorder and focus my career on helping those kids be part of family. And so that's, ever since that time, then I was driven for that. Well, I went to work for the Casey Family Program right out of graduate school. I got hired in Tucson, worked with kids in the foster care system to establish permanency in a family environment. Kids that had been abused, neglected, they didn't have any home. And so I worked for the Casey program in Tucson and worked with a therapist named Priscilla Meisner, who worked with kids that had attachment problems. And so I convinced Casey to hire her as a mentor for us to work with these kids. And so I worked with her to learn how to work with these kids. And so that just moved me in a direction of, somebody's got to be helping these kids. So I just grabbed on anything I could learn. But what I learned was, through parents of living with these kids. And so there was a pattern of behaviors that became consistent with these kids and all their families, and people weren't talking about it. And so I started to speak to groups, started to get more confidence in what I was doing, and then went to work in Colorado with a program that was working with attachment disorder kids, and worked with some gifted clinicians, some not so much, but I learned what to do and what not to do and what was comfortable for me. And so as a result of that, I developed a treatment program for attachment disorder kids called the Institute for Attachment and Child Development, and our office is in Littleton, Colorado. And so my philosophy was that these kids had to learn how to be reparented. They couldn't be reparented in their permanent home, like their adoptive home, or even in, where a bio dad brought them in with a stepmom. I mean, they just weren't able to make it anywhere, and residential treatment wasn't the answer because I had already worked in that environment and that wasn't successful. So I created a therapeutic model where professional parents could help these kids become family kids. They understood the dynamics, the pushback, the manipulation, all that. And so they were just gifted people that I was blessed to have work for me. The other thing that was helpful is that they weren't the nurturing enemy. They weren't the ones that the kids were in conflict with and could create this adversarial relationship of survival in the home. The kids pretty much had to fit into their model, into their care, which is what normal kids would learn in their bio families. They would fall into place according to how the parents framed the environment and guiding them and directing them. And so these parents were just gifted at reparenting kids from the emotional age of like 3. And so what do you do with a 3-year-old? You watch them all the time, you guide them, you direct them. They didn't have a repertoire of knowing how to control the environment because Mom Jan or Dad Tom, who were therapeutic parents, Jan is the most loving, strong mom you'd ever want to reparent one of these kids. They could manipulate her, and she never got mad at them. She would do the love and logic, join them with their struggle, but they all knew that Jan was the boss. She ran the home. And then Dad Tom would be the one that would do the exercising and take kids out for walks and bike rides when they actually were doing things the way they need to. That's what he enjoyed doing with the kids. So they would learn how to have fun together. So every single day they were learning a whole different way to how to be a regular kid in a family with parents in charge. Some kids took, months to get all that under their belt, where they actually were liking being a different kid, being respectful, responsible, easy to be around. Our average length of stay was 6 to 9 months. And then our therapists were all attachment specialists, and they would work with the family in the meantime, and we would do Zoom therapy sessions. So the therapist would run the case plan for each kid, and they were just skilled too. And then therapy, they would graduate once they were responding better in the home. So sessions with the parents were every week, but not necessarily with the kiddo yet. They'd be working with the parents around their PTSD and their anger and their fears and all of that. And then sometimes therapists in their hometown would be working with the couple on shoring up their relationship, things like that. So while the kids were doing their work, the parents were also doing theirs. So that when kids got better, parents were in a better shape to receive their kids back home. And then we had a psychiatrist that was gifted in knowing how to help regulate their brains. We had a neurofeedback specialist that was gifted in designing protocols for trauma. We worked with the school system to help kids be regular kids and families. So we always had our programs up in rural areas with smaller schools where we could work with the school closely to also integrate the kids into the school system, because most of these kids were in public schools. And then we had the sheriff's department working with us, so kids that would want to run away, the sheriff understood our program, and so the model worked really well. So it was like a circle of security where everybody working with that kid was working from the same playbook. So kids didn't have a choice but to get better. The kids that didn't get better really didn't have a chance to get better anyway. There was about 15 to 18% in our outcome studies, because we did pre and post measurement of their progress, that just couldn't get better. They were just kids that were too empty to have any kind of emotional buy-in at all to themselves or anybody else. But at least diagnostically we knew whether those kids could return to their home or not. And the kids that couldn't return to their home, we just had to strategize another way for parents to love them from a distance but not return home.
How is that model different than what you see parents experiencing now when they try to send their kids somewhere for treatment?
Well, it's the old traditional behavior modification model, typically in residential treatment, where kids are going off to a non-family environment. They're going to more of an institutional environment where you have rotating staff and they have a lot of rules and structure. These kids tend to do better in those environments because there's no attachment figure. They can figure out how to work the system and feel better there and behave better there. So, parents would get frustrated with that system because they weren't working with the family, and with the attachment problems, all they were doing is behavioral compliance. But kids were behaving better because they were away from their parents. So then the facility would say, this kid's doing well, they're coming home. They would go home and fall apart because they didn't have that internal working model about, being safe with a parent system. And then their parents were still stuck in their own survival. So then the kid would come back and fall into place with their control, and the parents would say, my kid didn't change at all. And then the facility would blame the parents because the kid did well in their facility. So there's a lot of folks in mental health that do the old model that worked with, some delinquent kids, but not kids that were attachment disordered. And that's a model that still exists out there today. That's pretty prevalent.
Here at RAD Advocates, you come back year after year as a keynote speaker at NavRAD because parents look to you as one of the few clinicians they've ever met that understands the reality of what they're going through behind closed doors. How does that feel for you, being one of the few people that gets it with long lines of parents waiting to talk to you?
Feels lonely and exhausting. And it makes me sad just because there aren't many clinicians out there that get what I've learned over 40 years about how to work with these kids and these families. So I want to still help them with and still take good care of myself as far as going into retirement. So I love coming to this conference and I love connecting with parents, but I feel kind of frustrated that we don't have the resources out there where we can just refer kids. Once parents understand what they need, it's just frustrating. So I feel obligated to train other clinicians to do what I do, or at least close to doing what I learned over the years. But it's a tall order. Typically when I'm doing trainings and workshops, therapists have been trauma informed. They understand that, there's brain, disruption through, abuse and neglect, but not much training on what to do about it. So when I'm doing workshops, parents are always agreeing, you got it right on, and they're bobbing their heads in the workshop, and the therapists are scratching their heads because they haven't lived with these kids. They don't have the same experience to put in context what I'm talking about, but parents do. So I've got several parents that either have a degree in mental health or they're in graduate school to do it, and they're the easiest ones for me to train because I don't have to convince them of what it's like, the nuances of living with these kids around their control.
What is missing from graduate school? I mean, based on what you experienced yourself and then what you hear now from other clinicians that are going through it?
I think the most frustrating part still with academia is that there's a lot of theory where they teach you about theory and diagnosis and personality problems and things. And then they hope that through your internship, you're going to get the skills you need. But I think you get the foundation of mental illness and what it all involves, but what's your experience to take it on? And that's where you just kind of luck out in graduate school to get your supervision and training with someone that understands this disorder. That's really, so it's almost like luck of the draw. And even when folks are trying to find a good internship or supervision, there aren't as many folks out there that are really skilled in this area.
How did you figure it out? What did you do differently?
Well, I think it was a lot of trial and error and a lot of listening to parents. I think being able to listen to what they were struggling with, and there was just a pattern of behaviors that were consistent with these stories. So lining up the symptoms and being able to assess the severity, because attachment disorder is on a continuum from attachment issues up to attachment disorder, mild, moderate, and severe. The DSM doesn't diagnose it that way. It's more general in what it is. But I've developed an assessment process and a way to measure this based out of my 40 years of patterns of symptoms and behaviors based out of their early trauma and their disruption in their development by just listening to parents, and then applying a reparenting process to where kids are stuck, because attachment disorders develop prior to the age of 3, even though the DSM says age 5. My experience says age 3, and that's all about developing a conscience and trusting that your needs will get met in a parent environment, working through the toddler stage of autonomy versus shame, guilt, and doubt, of understanding limits and rules in the world based out of your connection with your parents. So if we look at normal child development, these kids didn't have that. So how do we go back and reparent them based out of those developmental milestones that they weren't able to complete?
What are the most common questions that you get from parents?
Boy, most common. Is there help for my kid? Can this kid be in my home? Can you help me fix my kid? I get those all the time.
And your response?
It's hard because, when I had a treatment program for it, I'd be easy. Well, send them to a program. It's the best in the country for this. And I don't have that anymore because the facility closed down, back in 19, partly because of COVID and partly because of mismanagement and things. So I retired.
After you left?
After I left, yeah. So it isn't there anymore. So I get frustrated on where to refer. So the best I can do is assess the severity of kids to help them decide whether they have RAD or not, how broken their home is, their family, their marriage, all of that, and then recommend where to go from wherever they're at, based out of the severity of the kids.
What's your hope?
What is my hope? Well, I'd like to have another institute for attachment and child development somewhere. And I'm hoping that there's a place that has a treatment family kind of environment, like a Boys Town facility. I wish Boys Town would say, here, put your model here, because they have the infrastructure to do it with homes and parents and school. They have an on-campus school. My hope is that someday, while I'm still able to do this, for a facility say, we want you to come train us to do the institute model. That's what I'm hoping for.
Is there anything that can be done from an outpatient perspective?
There is, based out of severity. So kids usually in the moderate to severe range of attachment disorder, it's really, really tough to get those kids engaged in their own recovery because they're so locked into their own survival and control. So it's a really hard time for them to feel vulnerable with anybody being in charge of their life. So that's a tough part. So kids in the lower range have a better prognosis if they work with, a good attachment specialist. And that means working with the family, because I see the family as the client, not the kid. The kid is stirring up the family system. And so you have to have the family system more stable before kids are ever going to feel safe to give up their control.
And how is that different than a traditional therapist operates?
Well, typically there's still individual therapy that I'll meet with this kiddo and sort out their life and help them make better decisions. And with attachment disorder kids, they just see that as an opportunity to align with someone powerful. So they give them what they want, but they're blaming their parents for why they're not happy. So then if the therapist doesn't understand the dynamics of the disorder or doesn't meet with the family, they're aligning with the kid. And typically those kind of therapists then blame the parents for why their kiddos having problems.
If you could give an outpatient therapist just one piece of advice that would help parents without having the knowledge, the training, what would it be?
To listen to the parents. Yep. To be able to sit with them, recognize their pain, their suffering, their needs, and just be with them. So once you can sort that out, because some parents are so done and fried they can't do it anymore. Well, you're not going to do push attachment therapy when a parent says, I'm done, I don't even want to risk connecting with this kid again. You're not going to push that relationship, but you need to listen to the family. Because if you don't have the family base to work with, you're just feeding into the problem.
In what way?
By aligning with the kid against the parents.
What do you feel needs to change with regard to how the world sees and treats children and families, children with developmental trauma and their families?
That's an easy question. What needs to change? Well, I think that the system of child welfare needs to understand how they set, especially adoptive families, up for failure with these kids. So I think the system needs to be more attuned to the attachment disruption of these kids they represent and side with parents to give them the supports they need Because if we catch these kids earlier, they have a better prognosis. And so more upfront awareness about how to secure and treat attachment disruption in their development, because most of the kids that come to our clinic have all been in the foster care system or in orphanages where their developmental disruption is pretty clear to me. And so the system, instead of working against parents, they need to join with them. The dynamic, unfortunately, with permanency in foster care, we have laws in this country that are driven from the federal laws where you have to provide permanency or reunification for kids that are disrupted out of their birth families. So kids will go into temporary foster care because of some abuse allegation. Kids feel safe there, so the judge says to a birth parent, get your life together so you can get your kid back. They don't really treat the problem. They don't really jump in there to help that parent treat their own attachment disruption and problems. Instead, they just keep sending kids back to birth parents that haven't changed, and kids disrupt again, then they go back to foster care, they might send them back again for another try. And so now you've got the system helping to create attachment disorder because you got kids moving back and forth to safety, to fear, back to safety. And so they end up going back eventually when they decide, well, enough is enough, we're going to terminate parental rights. The kid has already been disrupted so much, and who are they going to blame? The parent that they felt safe with allowed them to go back to an unsafe situation. So it's a crazy system, and it really is ineffective. And I disagree with how to do permanency. I think that we should jump in there in the beginning and work with the birth parents. If we want the goal for kids to return home, treat the problem. And if birth parents don't want to really invest in their own recovery, why would you send a kid back? So you give them an opportunity to change their life and get better. If they choose not to do it, you move towards termination and permanency. And that way the system doesn't set these kids up for more failures over and over again.
So with all the frustration, disappointment, and obstacles you've seen over the course of your career, do you see any positives happening? Are we in a different place? Is there a course for change and hope?
Every time I come to this conference, it's the fourth year now, I get hope because there's people that are making changes. I think it's parents that are going to be the ones to change it. I mean, I had a parent a little bit ago said, yeah, I've got a neighbor that's a state legislature and he's head of child welfare. And so it's kind of like, who in this group knows somebody that's going to make a difference, that's going to listen to you so that you can make a change? Because it's the power dynamics, the people at the top that typically make these policies, and they really don't know what they're dealing with or how to support people. So I think it's these parents collectively pulling together to get behind RAD advocates to make the change. Because when I think about making the change with clinicians and universities and judges, it becomes overwhelming, and I get tired, and I'm not spring chicken anymore. So coming here just rejuvenates me to keep going and to keep trying to make a difference in the system. But I do know that I don't want to fight with resistant kids anymore. I mean, that just kind of wears me out, and I'm running out of resiliency. So if I can help in the way I'm doing it with assessments and some consulting and training, I'm happy to do that.
Well, we're glad that you're a part of it.
I am glad I'm a part of RAD Advocates for sure.